But before I tee up kind of this morning's discussion, I want to especially thank our sponsor, Rosecrans. We wouldn't be able to do this event without support. And I want to just give Jen, who's here, and a friend of mine, dear friend, thank you, Jen, an opportunity to say a few words.
Thank you. We are so honored and happy to be a sponsor this morning for this important discussion that we're going to have about the opiate crisis. You know, all of us in this room have a different seat as we at this discussion. Rosecrans has a front row seat. As a clinician myself, I started with Rosecrans as a counselor, an outreach counselor doing intake assessments. So I was dealing with our clients on the front end when they were still using and things were still messy and they were still really ugly. And most of those stories, most of the adults, most of those stories started, their stories of addiction started in the ER, in urgent care clinics, and in their own doctor's office. And so that's an important piece to keep talking about when we talk about the opiate crisis that's happening right now. So we're just really happy to be a part of this. Rosecrans, if you're not really familiar with them, we're a dual diagnosis program. We have 51 locations across the Midwest. A lot of people don't realize we're that large. We serve adolescents and adults on all levels of care, residential, outpatient, partial hospitalization, and we also serve residences. We're most proud of I'm most proud because I'm Chicago-based, of our Chicago location that opened last year. We're up in the Lakeview neighborhood. And a piece of that program is we serve all adults at that location, but we have a Launch to Life program, which is a specialized program for the emerging adult, 18 to 29. And the majority of those clients that come to us in that age group are struggling with an opiate addiction. So that's a piece of the program that we take their special needs into account. Our annual fundraiser is on the 26th of September. All of you guys will be emailed info on that, and that's a specific fundraiser for this Launch to Life program at our Chicago location. Pat O'Brien's going to be our guest speaker, and we're pretty excited about that, but we'll make sure you guys all get information on that, as well as a Florian Symposium that we're having at the end of September as well. Our Florian unit is a specialized unit at our adult location that specializes in first responders, so policemen, firemen, and ER personnel. They have a higher incidence of suicide and addiction rates than the military and the veterans. So we have we're only one of a handful in the country that have a unit such as that. So we'll be doing a symposium. For any clinicians in the room, it's a 2-day symposium on working with trauma clients. So we're really happy to be here today and turn it back over to Kelly.
Thanks, John. Okay, it's a great crowd today. Thanks everybody for being here. So you may know that September is National Addiction Recovery Month. So that's really timely for our topic today, addiction, opioids, and heroin. And it's almost hard not to read about these issues today. It's beyond just a healthcare topic. I'm a big National Geographic fan. Usually we read about Africa and Mars and things like that, but the cover of Nat Geo today, this month, if you haven't seen it, is addiction. Really, really interesting. It's everywhere in the news, and it should be. But today, as we talk about that and we talk about the trends and the statistics, I really just want to remember that this is really about families and about people that behind every number that we talk about, there's a human being and there's a family around them or a community around them that is experiencing this. And I couldn't help, I'm a big Sunday New York Times fan, and I couldn't help but thinking as I was reading on Sunday about some of the more recent data that they came out with that talked about even their most recent estimates for June were low, that it's actually, the opioid challenge is much greater than we previously thought. But they were also obviously talking about the devastation of Hurricane Harvey that's displaced tens of thousands. And the juxtaposition between these two disasters was really not lost on me. Families across America are experiencing an addiction hurricane. It just keeps getting worse. And the media is raising alarm, but the response has not been commiserate with the disaster. As we all know, the Opioid Commission recommended a state of emergency. There's been no state of emergency actually issued. This is not difficult, by the way. The commiserate federal aid has not at all been proportionate with the disaster that we're seeing. The interim report that the President's Commission issued was intended to provide the President with steps that he could take right now, like right away. That's why they issued an interim report, and none of those things have been acted on. There's been no funds to support families themselves. There's no rushing to their aid. There's no Red Cross for the victims of this disaster who are losing their homes and their loved ones and their jobs. There's no fund that people can go to, right? There's support groups, which is great. So I think that's just an important perspective to consider as we talk about this issue. This morning, I think some of you know that the governor of Illinois is planning to issue an executive order and to release an opioid action plan, literally right after this discussion today. So before you get back to your offices, we are hoping to send you a link to that plan and any information that we can have. I think the announcement is at 9:30 or so, which is why Director Shah needs to leave just a bit earlier today. The email that you get will also include a number of other resources and some action steps that you can take. It's my hope that the action plan actually results in action and that it is a high priority for our governor and our other elected leaders, and that the necessary resources, translate money, is provided to implement the urgent steps that are needed to combat the epidemic. I also want to note that I think some of you know that former Congressman Patrick Kennedy, our founder, is on the President's Opioid Commission. And the final report will come out in October. They're still taking comments on that report. I've had a chance to see some of those comments and actually seen the kind of compiled list. I will tell you that far and away, like 90% of the comments have been from marijuana advocates. They have mobilized and they are providing feedback about legalizing marijuana. That's great, but where's the addiction community here? We really do need more comments and more support for the report. So again, in the email, we'll talk about how you can do that. There's a link. Facing Addiction is circulating a letter that people can sign. But I do think it's important. You can also go to the White House website, and there's an opportunity to submit comment and review that report. And I think it's important that people weigh in. So I just wanted to mention that. And finally, I also want to point out before we dive in that reports also show that overdose rates are up for cocaine, for meth, for alcohol. The suicide rate is up at a 30-year high. So I hope that our panel today of public health experts can give us a sense of what's going on and what an effective public health response would look like for these kind of statistics if we saw this for other chronic diseases. So I should really stop talking and introduce the experts. This panel today is going to be moderated by Stephen Ross Johnson. Stephen, if you want to come on up. If you do not read Modern Healthcare, you should, and you should read Stephen. He wrote a really great piece about addressing the mental health toll that Harvey is going to exact. He writes much about public health and health systems, such as integrated care. He's been a freelance reporter for the Chicago Tribune, Progress, Illinois, the Chicago Reporter, and the Times of Northwest Indiana, and a government affairs reporter for the Courier News in Elgin, Illinois. He's a product of the Medill School of Journalism at Northwestern University, so none of this great work should come as any surprise to us. So, Stephen, I'll turn this over to you.
Good morning.
Good morning.
Let me just start then by thanking everyone for attending to this morning on this very important subject. Let me start now by introducing our panel. Dr. Grant Baldwin is the director of the Division of Unintentional Injury Prevention at the Center for Disease Control Prevention's National Center for Injury Prevention and Control. Then, of course, Dr. Nirav Shah is Director of the Illinois Department of Public Health. Next, we have Dr. Elizabeth Salisbury-Afshar. She is currently the Medical Director for Behavioral Health for the Chicago Department of Public Health. Thank you. Finally, we have Laliberte, who's co-founder and executive director for Live for Lali, a nonprofit that works for prevention substance misuse and raises awareness about harms associated with substance misuse. So, so thank you, panel members, for being here. Let's just start then with a, I guess, more obvious question. When we're looking at this current opioid epidemic, what is the scope of that? How big of a problem are we talking about, and how big is it compared to past epidemics of this sort?
Sure, I'll start and then others can weigh in. Drug overdose deaths in this country have never been higher. The latest numbers that we have is 64,000 deaths. What's changed in the last few years is the percentage of those deaths are now opioid related. So latest data from 2016 is showing around 53 to 54,000 opioid related deaths in this country, which is about 150 people per day. What's also changed is that we've seen a shift. This epidemic has really, there's been sort of 3 waves of this epidemic, which started with the prescription problem, plateaued right around 2011 at around 15,000 deaths. They started in 1999 around 3,000. But what has really ballooned in the last few years is first heroin and now fentanyl and the fentanyl analogs. So for the first time in 2016, heroin and the synthetics, excluding methadone, which is largely the illicit fentanyls, overtook prescription opioids. So the data that we have from 2016 that the National Center for Health Statistics just released showed around 15,000 heroin deaths and over 20,000 synthetic opioids other than methadone. And just to give you a trend perspective, in 2010 there was around 3,000 heroin deaths, and so that's now 15,000. And on the synthetic side, in 1999, there was 730 synthetic opioid deaths other than methadone, and now, as I said, that's over 20,000. So it's really, and we can talk about later on in the discussion about the changing landscape. But did the prescription problem facilitate where we are on the heroin and now the illicit side, the illicit fentanyl side? And the answer is it's complicated, and I'll go into that later if folks are interested.
Good morning, everyone. Before I dive into the numbers, I beg everyone's forgiveness. As Kelly mentioned, I do have to cut out a bit on the earlier side today. It is for another opioid-related event, so I'm not giving short shrift to the opioid problem. We're actually, as Kelly mentioned, going to be releasing an executive order in our statewide opioid action plan this morning, as well as this afternoon. So my apologies in advance for having to beat a hasty retreat. The numbers in Illinois are staggering. They almost defy belief. Since 2008, 11,000 people in Illinois have died because of an opioid-related overdose. Just last year alone, in 2016, there were nearly 1,900 opioid-related deaths. That number is difficult to contextualize. So what I tell people is that that's twice the number of people who died in a car accident last year, and 1.5 times the number of people who died as the result of a homicide. Sadly, the problem is projected to get worse and worse and worse. As Grant just mentioned, we too are seeing an increase in the number of deaths in Illinois attributable to fentanyl. It's actually quite shocking how stark that is. Just since 2013, the number of deaths that are attributable to fentanyl has gone from about 90 to 900. So a tenfold increase in the number of fentanyl-related deaths. Right now, we believe that if left unchecked, if the crisis grows at its current trajectory, we'll be looking at nearly 3,000 deaths in 3 years.
So again, my name's Elizabeth. I'm here on behalf of the Chicago Department of Public Health. I think when I look at this problem from a city perspective, I'm constantly sort of contrasting it to some of the things we hear and see in the news. And I think one of the things that we're seeing locally, and when I give these talks in communities, a lot of times community members come forward and say, Elizabeth, like, why is this such a big deal all of a sudden? We've been seeing heroin in our communities for a long time. This is not new to us. We've been dealing with this for a very long time. And, you know, don't you think that this is now just because, and this is what people say to me, because rich white people from the suburbs are having their children die of heroin overdoses? And my response is twofold. So I always first say, I completely agree. I think that you're right. There is a social justice dynamic. There is some, honestly, value to the fact that people with more means and more political resources are now being affected by this. And the scope of the problem has become so large. The increases in overdoses are affecting all communities. Certain communities definitely that didn't have high rates of opioid-related overdose are now being much more impacted. But many of our communities in Chicago that have been long impacted by heroin and access to heroin and heroin overdoses are now being impacted at a much higher rate. And I think really very specifically now with fentanyl on the streets and on the scene, people who may have been who have been using heroin for a long time, who had high levels of tolerance to the drugs, are now getting fentanyl and dying very quickly. And so the scope of the problem has continued to increase in all communities. But very specifically in Chicago, I think some of the trends that we're seeing are a little bit different. I'm happy to talk about those more later, but largely just with relation to sort of the age of the people that we're seeing who are dying tend to be much older. And we're seeing, not surprisingly, that there are very certain areas of the city that are being impacted at a much higher rate. And so we're continuing to really track those things and really understand what's happening here locally to make sure that we're best targeting resources within the city to make sure that they're reaching the communities that are being the most directly impacted.
Hi everyone, I'm so honored to be here. My name is Laliberte. I'm the executive director and co-founder of Live for Lali. And what Live for Lali is a nonprofit organization founded in memory of my brother, Alex, who died from a heroin overdose in 2008. Right when we all kind of started hearing about this opioid epidemic and nobody really knew what it meant. We didn't know what it meant. And so Lali is Alex's nickname, and in fact his birthday is next week, and so my family and I are gearing up to deal with that. And so the 11,000 Illinoisans, where our family is one of those families that have been directly impacted by this crisis and never saw it coming. So what I do, and what I'm honored to do every day, is work with people on the ground just like me, just like my mom, just like some of the drug users that we kind of see and we hear about, or we think we have this idea of what they're going through. But to look in the face of a mom and to look in the face of somebody who desperately, so desperately wants to get out of this, but is so limited with resources, limited with support, limited with their own self-stigma, the stigma that the outside world creates for them, undiagnosed underlying mental health illnesses that they were never treated for. And I see demographics of all walks, and my family is one of those rich, upper middle class white families that did experience this and did something about it. But on the ground, my unique perspective of impacted and also counselor is that I see my brother in every single person that I work with. I see someone who is good. I see someone who is kind and compassionate. I see somebody who just wants to make something of their life. We did not see this coming, and for all of the effort that my colleagues and I in the field, working with users every day, deal with, we do a lot, and we're not really seeing the ROI, so to speak, the return on our investment for our lives and what we put into this. And really it all comes down to the families. So I think when it comes to the national perspective, what it does to families, we're still clueless. There's still a huge amount of information they're not receiving, a huge amount of just recognition of how to treat substance use disorder, that it isn't your fault. So, I mean, we do have still a long way to go, but I think we've come very far to the point where we're able to have this conversation here today. So, hopefully my perspective in that regard will be helpful.
Let me just add, Steve, that there are 360,000 of those stories since 1999. That's, just stop and think about that number. 360,000 people have have a similar story as Chelsea's family has experienced. Just incredible.
A lot of talk has been discussed regarding public health approaches toward this current crisis, and I would love to get your definitions as to what that public health approach looks like in form and how you in practice.
Well, at CDC, first let me say that former CDC Director Frieden framed in RX Summit talk a couple of years ago a way of thinking about this problem which really resonated with me. And he said there are really two sets of groups of people that we need to focus on. Those people who are already addicted, that is increasing access to medication-assisted treatment, methadone, buprenorphine, naltrexone, the wraparound services associated with that, and expanding access and availability of naloxone to prevent overdoses that are in progress and make it widely available to the point that we can deal with the potency of the fentanyl and the fentanyl analogs, and then stop people from becoming addicted in the first place. And this is where dealing with inappropriate prescribing, this started largely because of prescribers using opioids to treat chronic non-cancer, non-palliative, non-end-of-life care. And then the other thing he mentioned was building bridges between public health and the public safety or law enforcement community, which really makes a lot of sense, especially as we've seen this migration to heroin and fentanyl. At CDC, we have 5 specific things that we're focusing on, sort of improving data, tracking trends, both the quality and timeliness of data. We've received some constructive feedback, I think justified constructive feedback, that it's really hard to know where we are with our fight on this scourge if we're 18 months to 2 years behind on the data. So we're working very hard and funding states to help improve the quality and timeliness of data. Secondly, trying to stand up, giving states more resources to implement and scale up evidence-based programs. We just yesterday announced an expansion of what we're framing as our overdose prevention in states initiative. So it's actually 3 programs in one, but we're funding 45 states and the District of Columbia $125 million to enhance and maximize prescription drug monitoring programs, implement community or health system interventions, conduct policy evaluations, so when state officials or local officials take action to address the problem, do those policies and regulations work? How do they work? Improving surveillance, and then giving states on a year-over-year flexibility on how they spend their resources as this epidemic evolves. Many of you have probably heard the third pillar of our work is in the prescribing guidelines. We released opioid prescribing guidelines for chronic pain in March of 2016. We're in the process of implementing those on what we're doing in that space. And then the 2 sort of new ones is this building bridge between public health and public safety. We are most notably working with 8, soon to be 10 or 12 high-intensity drug trafficking areas to build bridges between drug information or intelligence officers and public health analysts to make sure we're sharing information and doing targeted hotspotting, and then increasing public awareness about the problem. So we're specifically focused right now on the prescription side. So in a few weeks, we're about to launch a large-scale communication campaign called "It Only Takes a Little to Lose a Lot. Prescription opioids can be addictive and dangerous." We piloted the program in Rhode Island, Oregon, Ohio, and West Virginia. And the communications people who I have on my staff were just so enthusiastic. Many of you have probably seen the Tips for Former Smokers campaign. It uses a similar model where we use both recovering addicts and surviving family members telling their stories about how the impact of the epidemic has impacted their lives. Just incredibly powerful. These are the kinds of stories that you're likely to have a tear in your eye at the end of watching it. We've got a huge response, 141 million impressions of the people who've clicked on the material. Almost 30% are actually watching it through its entirety. So again, these are, given the polls that we all have with our smartphones and other devices, getting people to actually watch completely through, we're really, really excited about. So I can tell you a little bit more about that program if you'd like as well. So that's the CDC, and what we do is work in concert with our other federal partners, FDA, SAMHSA, et cetera.
For me, the public health approach with respect to the opioids, where public health is really at its best, is along 2 fronts, 2 axes. The first is along the prevention front. And I'm proud to note that the first plank, the central pillar in the action plan, have I mentioned that there's an action plan that's going to be released? The first plank of that is prevention, as well as treatment and then rescue. The other area that I think public health is at its best is with respect to stigma reduction, what Chelsea mentioned. So on the prevention piece, for many of you in this room, that's what Dr. Baldwin mentioned. That is to say, taking individuals who might find themselves at risk for future opioid use disorder and attempting to avert that risk. Prevention's tough. It's difficult to quantify. There's not really a constituency around prevention. It's difficult to make the case for prevention when there's so much immediacy to the crisis. But clearly, and as many of you in this room have likely heard folks say, this is not the sort of crisis that we will be able to arrest our way out of, or probably even to treat our way out of. Prevention is really going to be the bedrock principle. In many regards, the opioid crisis is the HIV crisis of our time, in many respects, in terms of the number of people who've been affected. Around 50,000 or so at its peak for HIV, and around 50 or 60,000 with respect to the opioid crisis, as well as in terms of the types of folks who are affected, people on the margins of society. But most importantly, that we didn't really make a dent in HIV until we really zeroed in on the prevention piece. So there are an amazing number of parallels. The other area of the public health approach that we are really dramatically trying to increase our activity on is around stigma reduction. Now, stigma in public health is a sticky wicket, right? Sometimes we want to reduce stigma, HIV, opioids. Sometimes we increase stigma, smoking, alcoholism. So it's tricky. We use stigma both as a sword and a shield. And we have to try to figure out what the right set of tools is to reduce stigma, because if we don't do it right, we could increase the stigma. What I will say, just as a personal anecdote, is not only is it very difficult, but about a year and change ago, my team and I were in Effingham, Illinois, down south, and I met a woman who was talking about her son who had died of a heroin overdose. And what she told me was that when your son dies of leukemia in a small town in southern Illinois, everyone in town shows up. Everyone brings you a casserole, everyone shares in your grief, and everyone shows up to the funeral. But when your son dies of a heroin overdose, alone with a needle in his arm, no one shows up. No one brings you any food, no one is there to feel your pain, and no one comes to the funeral. So the effects of this stigma are immeasurable and real. And it's not until, just as with HIV, that we start treating these folks, as Chelsea said, like human beings who have a problem, a medical problem, and that treatment is in reach, are we actually going to start making inroads?
So when I think about sort of public health or population health response to opioids, in sort of some of our strategy right now, sometimes what I feel sort of like we're throwing everything against the wall. And when you're in the middle of a crisis, that's what you do, right? Like you're throwing everything in the kitchen sink. So we're trying a lot of interventions at the same time, while hopefully simultaneously evaluating their impact. And there are a few areas that we know have an impact, particularly around reducing mortality. And this is from the evidence base from the literature. And so one is around prescription drug monitoring programs, really with the focus and emphasis on trying to reduce prescribing. And so at the national level, we've seen that the more robust a prescription monitoring program, sort of the more impact it can have in reducing prescribing, the more impact it can have in reducing mortality. For us in Chicago specifically, we actually have really low prescribing rates. And so both compared to the rest of the state, but also as compared to the rest of the country. And so for me, I'm constantly sort of struggling with what does primary prevention look like in a setting where prescribing rates are already low. Without question, we could, I'm sure, do better. But if we don't have large volumes of prescription opioids in the community, sort of what does our primary prevention strategy look like? And that's an area where I really hope to see increased research moving forward, because today I don't have a good answer for you. The second area is around MAT, medication-assisted treatment. And for people who aren't familiar, again, these medications would include methadone, buprenorphine, and now naltrexone, although the evidence base for naltrexone around reduction of mortality is not quite as strong as it is for buprenorphine or methadone. But I think here, when we talk about stigma, we also need to talk not only about stigma of addiction, but stigma of treatment. And so within a lot of the addiction community, there's actually a lot of stigma against the use of medication, which as a physician, as an addiction physician, as a population health physician, just makes no sense. In terms of, we actually have addiction treatment providers who, quote, do not agree with the use of medication, even though the evidence base for opioid use disorder specifically says that people are more likely to stay alive, people are more likely to be maintained in treatment, if they receive medication in addition to other behavioral supports. And so I think we need to include stigma around treatment in that conversation. We know that buprenorphine and methadone treatment programs have been shown to reduce mortality. There's a study out of Baltimore that actually showed almost a 50% reduction in mortality as they were able to increase capacity for methadone and buprenorphine treatment. So I think that is another area where we really, in terms of investing energy and effort, we need to do so both with dollars, but also around the stigma reduction. And the third area at a population level that has a strong evidence base for reducing mortality is around naloxone distribution. So for people who aren't familiar, naloxone is a medication, Narcan is a trade name for it, you may have heard of that. Naloxone is a medication that can be given to reduce an overdose. A lot of times when I talk to communities, and even sometimes when I talk to medical professionals, they say, how could we possibly give people a drug that's going to reduce an overdose? That just means people who use opioids are just going to use more opioids. And what the literature says is actually that that's not true. The literature tells us that people who have access to naloxone are actually not going to use more drugs, and they're more likely to eventually engage in treatment. And so I think that we need to be doing everything we can to make sure that any interface that we might have with people who are using opioids, any interface we have with people who might be at risk for an opioid overdose, that we need to make sure that they're leaving that encounter with naloxone in their hand. Whether it be from an emergency room setting, whether it be from a treatment setting, whether it be from an encounter or being incarcerated. We know people leaving incarceration are at extremely high rates of overdose risk. And so really making sure that these three things that have a strong evidence base, that we're sort of pushing full force, and that everything else that we're trying, that we're constantly evaluating to know what's working. And so from a population health standpoint and an evidence literature standpoint, those are sort of the things I see that we know are working, so we need to continue to invest in them, and we need to continue to try new things, because as we can all see, this has not been enough. And so really making sure we're evaluating everything else we're trying.
We were lucky because when Alex died, so many people came out and supported us, and I know that that's not the case in every situation, but there was so much misinformation with that. First question was always kind of like, didn't you know? Didn't you know? So no was the answer. We didn't know because, as we know now, it's very hard to track when somebody's misusing prescription medications or heroin, and you don't know what to look for. And this was a time when we had no knowledge. But so how do you take, what you have and building a recognition in a community that there is a problem, which is really the question that we were trying to answer as a family. So our goal at the beginning of doing whatever we were doing was, let's just make a case. Let's just talk about this in the community, share our story, and maybe people will latch onto it. What that became over the years, the last 10 years in fact, was a responsibility to do this right, not just to throw spaghetti against the wall and hope it sticks. So without the CDC, without the IDPH, without the health departments, and without, frankly, Roosevelt University, who helped develop our model, we would have no clue what to do. We would probably still be in schools just talking to kids and hoping and praying that worked, because that's what we thought as a family and believed would be the key. But we have since learned that we actually don't have a lot of evidence-based educational programs for youth. We certainly have a challenge when it comes to parents coming out and schools being receptive. So where do you go with that when it doesn't really seem to be working and you keep kind of getting this hand-up approach? So Roosevelt University's Illinois Consortium on Drug Policy, so I started out doing this work as a marketing professional. I was not a counselor. I didn't just come out, and it didn't just happen like that. Having that background in marketing really helped me to figure out how to talk to people about this. And that was one of the things that we noticed early on. So how do you take messaging and translate it into action? That was always the concern. So the CDC came out in 2009 with these great recommendations. So one of them was, make sure drug courts have MAT, make sure that the public knows about MAT, make sure families have naloxone. So we took that and we're like, okay, well that's what the data is telling us, so we should probably do that. So ever since we started this, it's been about first learning from our mistakes, second following the data, and we will continue to do that. And what the data is telling us is everything that they have said. So how do you take a stigmatized topic, people who are not willing to listen, and create an opportunity for them to get trained in naloxone, get educated on the appropriate treatment recommendations, and have a supportive family systems style structure that works. It's real hard, and we're still not doing it well, and we need to be doing it better. So one of the things that we decided to do was create a resource center where people can come. Literally, it's just a place where people can drop in to get help and information. We launched that program in 2015, and since that time, we've seen over 10,000 people come through our doors. 10,000 people, that's a lot of people. And I think what's helped is the support of the community. So how do you translate these concepts into action? You get creative, and you follow the data. We have trained almost 20,000 people in naloxone. We have given out over 20,000 kits in the suburbs in naloxone. But there's still today this kind of missing link barriers between what happens next, what are the evidence-based recommendations for how we should be approaching this, not just having naloxone in the house. How should I be interacting with my child? How should I be, am I enabling my child if I allow him or her to stay with me and use? No. We know that safety comes first. We do it when we get in our cars every day, when we're driving here, we put on seatbelts. It's the same kind of concepts. But because of the myths and biases and social norms we have and things we learned in through the last 60 years of, frankly, the war on drugs, I hate to call it that, but this does have a lot to do with why we think the way we think about this issue. I think there's created this unbelievable amount of ideas that just simply aren't true. And so we need to be re-educating communities about that. So it's very complicated when you want to start something like my family has started. And I've seen a lot of nonprofits fall by the wayside because they didn't have the support, they didn't have the board, they didn't have sustainability models, they didn't have strategic plans. Hell, I didn't even know what that was supposed to look like. Governance? What does that look like when you're just trying to do something important and help people? So translating the data into action is something that's really hard to do, but I think in Illinois we've done it really well because we think about what is our goal at the end of the day. Our goal is to save lives. Our goal is to make life easier for families who are experiencing this. And so I think that is what we need to continue doing and continuing bolster the opportunities for organizations and communities, smaller communities, larger communities, rural, metropolitan, suburban, to do this, because this is important, and it can't just be the IDPH, it can't just be the CDC, it can't just be CDPH, so many acronyms, it has to be all of us, and so how do you do that when there's this high of an issue, so.
In terms of strategies that you mentioned before, the widespread distribution of naloxone that's been done in several cities, including Baltimore and such. I'm just curious as to why we haven't seen kind of other innovative strategies out there right now. There have been talks of safe injection sites, more needle exchange programs and such of that sort. Why haven't we seen a real push toward more innovative strategies such as those?
Uniquely qualified.
So I think oftentimes underlying all of this is stigma, and I know that continues to come up. So when we talk about innovation, so you specifically mentioned safe injection facilities. So for people who aren't familiar, safe injection facilities are physical spaces where people can go not to buy drugs, but to use drugs. There are people on site who could save their life if they overdose. They also provide clean equipment. The last study I looked at said that there are 66 cities in the world that have them sanctioned facilities. And most of the literature based around safe injection facilities comes out of Vancouver, British Columbia in Canada. The literature base is really strong out of this one site in Vancouver. But when you start to talk about sort of why aren't we doing it yet in the US, and there's been a lot of conversation in a variety of cities across the country, one piece of it is the legality of it, so it's currently illegal to have such a facility in the US. And the second piece, I think when you really talk about, well, why is it illegal? Some of it goes back to the war on drugs, some of it goes back to the stigma around drug use itself. And sometimes when these conversations come up in public health settings, people say, well, isn't this the same conversation we just had about syringes like a decade ago, like around, basically giving people access to clean syringes? And I think in many ways the answer is yes, there's a lot of similarities in the conversation. There was an article that just came out within the last month in the American Journal of Preventive Medicine where 2 researchers had been evaluating an unsanctioned safe injection facility in the United States. So basically a facility that's been running but without legal backing, and they evaluated it basically just to show feasibility. So I do think that there's a push for some of these conversations, but I think when it comes to innovation in this space, as has already been mentioned, we would all love to see innovation in primary prevention as well, so basically trying to reduce the initiation of use. There isn't a ton of literature based on what that looks like, so I think we could use innovation in that space. I think there's a lot more research to be done in treatment, and exactly which treatments are the most effective, and what type of behavioral interventions in combination with medication are the most effective. We have an evidence base, absolutely, but evaluation is expensive, and a lot of times people don't want to fund the evaluation arm of studies, and it is expensive. And then the same goes for a safe injection facility or other types of innovations. It's one cost to sort of invest money in it, and then it's a whole other cost to invest in the evaluation arm. And I think we're very much at a stage right now where we need to be trying all different types of things, but we also really need to be studying the impact that they might have. And so just to give some examples of the literature based out of, again, a single site in Vancouver, is that they've seen a reduction in death, they've seen increases in linkage to treatment, they've seen reduction in public disorder. They've seen reduction in public use, so they've seen reductions in HIV and Hep C transmission. So they've seen a lot of positive outcomes out of this single site. But I think, the next phase is really to look at the legality of that in the US, and to look at very specifically, if we're going to try it, making sure that we're also evaluating it to make sure that it's being done and that there's fidelity to the model and that we're seeing similar positive outcomes.
If I could, sorry, Chelsea, before I excuse myself, I just wanted to build on what Elizabeth said. There are innovative policy lab ideas out there. We're exploring a few on our own in the state with respect to different ways to look at data, to target response and such things. But one response, and this is, I hate to fight the question as it were, but there is a lot of push and questioning around, well, why isn't there a silver bullet here? And there are instances in public health or in society when what you need is a truly innovative silver bullet solution. But there are other types of problems where that's not necessarily what is needed. And I think the opioid crisis falls in that latter, where innovation would be great were we so lucky, but it's a situation where really we ought to think about walking before we run. The solutions to the opioid crisis, or at least the inroads, are well known, they've been documented, there's literature around them. Right now we're facing more of an implementation gap than an innovation gap. At least that's one way to look at it. Maybe perhaps controversial, and I'll just leave that there and you guys can tell me I'm wrong as I take my leave. So my apologies everyone, but you are in very good hands.
Thank you, Dr. Shah.
Thank you, Dr. Shah.
So this is a controversial thing I'm about to say, but who cares? We're here, right? So we have to look at our policies. I mean, we talk about innovations. There are countries, frankly, who are doing this better than us. We always want to be the best. We're America. Sorry, but we're not winning this. And it's my job as an advocate to say we're not, and to suggest that there might be other alternatives to the way that we've been handling this. And a lot of it does have to do with the way that our policies are set up. Incarceration rates are incredibly high, and it's creating less opportunities to actually help people on the front end. So what we've had to do is resort to diversion and deflection programs, which I think are genius, and I run one in Lake County. And since we launched our diversion program as a countywide model in June 2016, we've had 200 people use it, meaning they can walk into a police department and access treatment through them without the fear of arrest, and talk to a police officer who's going to meet them where they're at and not judge them, and give them a hug and give them some food and treat them like a person who's struggling. So there's that, but also taking a look at the other issues that not changing our policies touches. One being poverty. We still have surges of poverty and racism. There are so many institutionalized issues that have come out of our policies. And then we look at countries like Portugal, and we see what Portugal has done with a decriminalization model, where they've seen unbelievable reductions in all the things that I think Dr. said, yeah, sorry, Elizabeth. She's my friend, so I'll call her Elizabeth. So we have to look around and we have to look at the data again and see what's working and see what's not working. And I think a lot of people will come out and say, oh, we can't just drop that model into America. Well, we don't always just drop models into a place as a template function. We customize it for our culture and our communities. But we're not even considering it, and I think that that's something that's really hard to wrap my head around because we see so much success with that. And also, as somebody who runs a needle exchange program in a suburb, Round Lake Park, which is all the way up north where we run ours, we have received an unbelievable amount of positive feedback for doing this in the community. The state's attorney's office has written us a declaration that we can operate this program. We've had all the police agencies in the county say we will not arrest anybody with needles or, so they've been pretty open-minded to it. I think we just need to kind of look at the strategies that are working and that have seen some sort of success and adopt them and just not be afraid to do that just because of the harm reduction word being so scary.
The only thing I'd add to it is, at CDC, obviously we're very data-driven, but we really pride ourselves on focusing in on the biggest modifiable risk factors. And then under Dr. Frieden's leadership, he really pushed us to find those state and local wins and do our best to showcase them to get them scaled up. He had a big emphasis on scalability. How can you bring innovation to scale? And so when we think about the innovations within this space, we're very worried about can this innovation be brought to scale?
As been mentioned before, the President gave an announcement regarding the state of emergency when it comes to the opioid epidemic. It has yet to materialize. I'm just curious, I wanted to get your thoughts on what that looks like in implementation. Once the declaration is made on that regard, what is that going to do in terms of mobilization of resources and funds? What can we expect?
Yeah, I think it's largely two things in my mind: a mobilization of resources to do things like mass purchasing of naloxone, as well as standing up emergency operations centers. We're very interested at CDC in identifying and targeting those hotspots, as we've seen on the illicit side, how best you can do that. Whether it's an official state of an emergency or if it's just activation, something different needs to happen. Because, as was mentioned, the problem's just getting a lot worse. And many states, I think 14 was the number I last heard, have already declared states of emergency, and we're in the process of trying to figure out what is the best model for when a state identifies and calls out a state of emergency. What does that mean? How is that best implemented? And that's it's an open question because, again, as I was mentioning to Kelly before we got started, unlike natural disasters, this epidemic is going to be with us for some time. Even if we're decisive and take really bold action in the next year or so, it's going to take us a while to get that back. Prescribing, again, we're prescribing at around, it's lower than it used to be, but at its peak, we were prescribing at 259 million prescriptions in this country. The highest prescribing state at the time in 2012 was Alabama at 142 prescriptions per 100 people. We in the United States consume 80% of the world's prescription opioids. And so if you think of a world of 7 or 8 billion people and the 300 or the 240 million adults in this country, it's hard to imagine that we're consuming 80% of the world's prescription opioids, but that is the case. And so we really have a long way to go. This tide is not going to turn on a dime. It's going to take us some time. But Elizabeth, what are your thoughts on states of emergency?
I think I have more questions than I have answers in terms of how things will change, both in terms of resources and our general approach. In general, I would say that my hope is that we will invest in short-term and long-term solutions. And so when we think about scalability, I think one of the things that we've seen happening in recent years is that we're sort of throwing money as quickly as we can into some of the things we know work. So like MAT or naloxone distribution programs, which I think is the right move. But we're very soon going to be hitting our capacity in terms of how much the system can hold. And I see several addiction treatment providers in the room. And so I'm sure everyone would say we could always use more money. But at some point, when I talk to people, really finding qualified staff, we aren't training enough addiction professionals. We don't have good opioid education in most medical school curricula. We don't have enough addiction fellowships for physicians. We don't have enough LCSW, CADC programs. And so I think there are a variety of ways in which we can also start investing in infrastructure. Creating treatment systems in this country have long been extremely siloed from the rest of the medical field. That's not going to happen overnight. Like trying to start building those linkages, pulling this in, recognizing that this is part of a whole person care. Those are very long-term solutions, and I'm hopeful that we'll also start thinking about some investments that will really allow us to build out infrastructure so that we can continue to really expand access to treatment. Because the other thing I worry about is even if we have a lot of investment of resources for the very short term, we're going to hit a place where we don't have enough additional capacity to continue to absorb because we don't have the workforce, we don't have all of the infrastructure in place to be able to provide the services that people need. And so I'm hopeful that part of that sort of state of emergency will include both short term, but also sort of planning for how are we going to continue to increase our treatment capacity and our other sort of harm reduction based programming.
I don't really have that much to say other than this national declaration should have happened 5-6 years ago. I mean, this is ridiculous that we're even having this conversation about if it should happen. To me, it just seems silly. But I do agree that, you know, for example, when we're talking to emergency departments and saying, hey, are you guys offering MAT? What are you doing in your emergency departments to help people who are coming in? And a lot of the time I hear, well, sometimes we offer them treatment. It depends on who you ask, you know, and where you are. But there's a lot of resistance to implementing naloxone programs within emergency departments, for example, or having a recovery advocate sit with somebody, you know, as other communities across the country have done. And I think what the feedback that I hear from professionals and from the agencies at the state level is that we don't have the infrastructure to continue to provide these services. So I totally agree with my colleagues. We know it needs to happen, but how do you put, again, like the theory to practice, and just do that when it's not set up to be done that way? So I think we have a lot of, we'll see. It'll be very interesting.
Steve, can I just mention, one of the things I wanted to make sure I got across in our time together was around this notion of narconomics. And people have asked me often, so how did we get into the fentanyl issue? Why has fentanyl become such a big deal in this country? If you, on a wholesale basis, a kilogram of heroin costs around $6,000, makes a nefarious drug trafficker several $100,000. Obviously requires cultivated poppy plants to develop. Illicitly manufactured fentanyl can be done in a laboratory clandestinely. Costs around $4,000 per kilogram, is cut in 16 to 24 kilograms of heroin or other drugs. That, you know, as Kelly mentioned, we've seen deaths go up in things like cocaine. And other drugs. That $4,000 investment, which obviously does not require poppy plants, generates a nefarious drug trafficker $1.6 million. So you have a very potent, lethal high that makes, if you're a drug trafficker, it makes you a lot of money. And it's also because, you know, I can't remember where I saw this graphic, but in one of the media reports, they juxtaposed a potentially lethal dose of white powder heroin and a lethal dose of fentanyl. And it's literally grains of what you would think of as grains of sand. What does that mean for trafficking? It means that these drugs are being trafficked and distributed across this country in some instances by US Mail, UPS, and FedEx. Because again, these small granules are hard to detect, they're easily shipped. And so you can easily get drugs across this country using those, what you would think is, it's actually a fairly sophisticated way of distributing drugs when you think about it. But my point is basically there's a narco-economic component to all of this that is driving how we got to now, independent of the lethality and potency of fentanyl itself.
Thank you. Now open up questions for the audience. We give the audience an opportunity to ask our panelists some questions.
In reference to the fentanyl, because the biggest thing that people ask me is why is the, quote, drug dealers, drug cartel killing their market knowing that fentanyl is killing the people?
Yeah, I think, you know, I'm not sure I can answer that question. It's hard to say. And I would say that, you know, one of the things that nationally, folks who are the profile of heroin or illicit fentanyl deceit tends to be a little bit younger. than the prescription opioid. So it's a slightly different drug user profile, but maybe Elizabeth or Chelsea, you have a perspective on that.
I would just say that I don't think it's any drug dealer's goal to kill their clientele, for lack of a better word. Nor do people who use drugs take drugs with the hope of overdosing. I mean, obviously there may be the occasional circumstance where someone is purposely trying to commit suicide, but that is the rare experience. I think a lot of it comes down to market forces. And so the other thing that we've seen here, and it's really kind of variable depending on where you are. I have colleagues on the East Coast who say that their heroin supply or opioid supply on the streets is 100% fentanyl now. In Chicago, we're seeing a good mix in terms of what we're seeing both in overdose deaths, but also what we're hearing in terms of drug seizures, where there's often a mix of heroin and fentanyl. When we talk, so I also am an addiction physician and I continue to volunteer half day a week in addiction clinic. When we talk to our patients, they don't really have a sense of what they're getting when they're buying drugs on the street, especially in a market like Chicago where there's such a mix. And then we were just mentioning before, in the Southwest, much of the heroin supply is still what's considered called black tar heroin, so it looks really different, and they're seeing almost no fentanyl. And so I think if I had to speak a little bit about what's happening locally here right now, it feels a little bit like the Wild West. For lack of nobody knows what they're getting, or very few people know what they're getting. I don't think necessarily that a lot of the drug dealers know exactly what they're getting, how much fentanyl, how much heroin. And generally speaking, people who use drugs are pretty savvy with their drugs and their drug use, especially more experienced individuals. And they want something that's going to give them the most bang for their buck, right? It's market sort of economics. And so if you hear that there's a strong heroin supply that still costs the same amount, still costs $10, for example, you're going to go for the thing that typically is stronger for less money just to make your dollar go further. And so I think it's a very confusing time right now, at least here. Again, in some places in the East Coast, they're pretty much seeing strictly fentanyl, and in those cases, people probably have a better sense. We're seeing so much mixing here that people I don't think, have a great sense.
I think those are great points. I'd also add, she sparked in my head this notion that, I think there's a fine line on potency here. It's very, very, the point of lethality, your margin of error is very, very small. We, as you probably know, at CDC had to release a health alert to law enforcement personnel and EMS providers who were on scene, who are potentially at risk of being, exposed to fentanyl. And we've seen cases where overdoses had to be reversed among EMS and law enforcement personnel because of their exposure to fentanyl at the scene of events.
Hi, on the subject of narcoeconomics, it's a sort of a flip side of it. I was wondering if you have any concerns about big pharmaceutical companies driving public health policy. We've heard stories recently about Alkermes aggressively marketing drugs like Vivitrol to judges, and I'm wondering if you could comment on that.
I think it's fairly benchmark fact at this point that there was, how we got to this problem on the prescription side was a misconception about the addictive potential of these drugs, aggressive marketing of these prescription opioids to clinicians who are undertrained in opioid prescribing, and the very small percentage of providers who are running pill mills looking to profit from the sales of these drugs. So I think it's a fair point. I think if historically, even now, when we look back at how we got to this point, I think it's a reasonable argument to suggest that the pharmaceutical companies played a role in marketing these drugs in ways that were not in line with what the outcomes would be.
I'll just add, one thing that we've done in Chicago very recently, people may have heard about it in the news, is that we actually instituted a pharmaceutical representative license. So all pharmaceutical representatives who are working in the city of Chicago more than, don't quote me, it's either 10 or 15 days per year, so people who are primarily sort of working in Chicago have to have a license. What this licensing process does is it also allows for any medical provider Although theoretically a judge could probably report it as well, to be able to report if they believe that the pharmaceutical representative is having any unethical practice. The other thing that it's done is that it requires that they complete at least 5 hours of continuing education every year, and there is a strong sort of ethics component to those educational mandates. Additionally, the revenue that this is bringing in has allowed us to free up dollars that we're using specifically for medication-assisted treatment in the city of Chicago. I realize it's not necessarily going to address all of the problems, but I think that these are very real concerns. Pharmaceutical companies are very good at marketing, and their main goal is to be able to promote the drugs that they're creating. And so I think, definitely within the medical community, we need to really be careful and be thinking about when we're hearing information, really questioning it and really looking at the data and what does the data show. But simultaneously, we really, as public health, need to be thinking about who else are they marketing. Like marketing directly to judges is a really new sort of space to be in. Direct marketing to consumers has been happening for quite a while, but also sort of we need to catch up and really be thinking about how are we working with criminal justice, how are we working with judges, what are we doing to make sure that they have evidence-based information. I know the Illinois Criminal Justice Information Authority, ICJA, I've been working with some folks there. We just put out an article, and we're really trying to make sure that criminal justice people working in criminal justice have access to the right information about medication-assisted treatment and really understand the outcomes associated with each of those modalities. And I think we also really need to question, kind of going back to what Chelsea said earlier, does it make sense that judges are even in a position to make medical recommendations? And so I think that a lot of it comes back down to sort of our drug policy, and I think that there are some positives in terms of thinking about things like drug courts, but we also need to think about sort of the structure of those and are they set up in the best way possible to ensure the best outcomes.
I think we got a question over here.
Thank you. You spoke about training for judges and for medical professionals. From your 3 different perspectives, if you had out of a 40-hour training first responder, law enforcement officers, and corrections, what would you cover in 10 minutes in terms of what you would want them to know for Monday morning when they go back to work on the street or in the jail?
If there's time, I'd love to talk a little bit more about what we're doing on educating clinicians on the opioid prescribing guidelines, but to answer your question specifically, we would really hone in almost exclusively around naloxone administration and making sure they're trained up about proper administration, making sure how they know how to handle patients in the midst of an overdose.
And I think as somebody who does train first responders, I'll say that you can do a quick training on overdose education and on compassionate interactions with drug users, because I think a lot of the resistance that the people at the street level and law enforcement specifically have is just this clashing of authority kind of stuff and culture. But if you just listen and talk to them like they're people and just and offer them things, for example, like, do you have clean needles? Just asking them questions like that. It really does make a difference in how they'll respond to you. And I think more and more law enforcement authorities are realizing that that's working, especially, well, I just know just because up in Lake County of a lot of the work that we're doing. But there is something working with that, and I think it can be done in combination. And I think just teaching somebody about overdose prevention specifically doesn't necessarily translate to this is how you should be talking to somebody on the street. So
I would argue that we need a lot more than 10 minutes. I worked on some of this education when I was in Baltimore, but I think one of the things, even often medical, I'll say physicians, because I'm a physician, don't recognize is that one of the quintessential sort of components of addiction is that people continue to use despite negative circumstances. Despite negative outcomes, excuse me. They continue to use despite negative outcomes. And so I think the first thing is that addiction is a chronic condition, treatment works, and naloxone saves lives. Like, those would be the 3 messages, but I think we have to get past the point of thinking that if we just lock someone up, force them to go through detox, they're going to get so uncomfortable and then they're never going to want to do it again and they're never going to use again. And then we release them and they go back into the exact same community, the exact same circumstances. with the idea that they're not going to use that, it's not working. And so we really need to rethink that. And there are other deflection reversion programs, treatment. I mean, even the point that, you know, if there was an article written recently by Sam Quinones, who I think is a great author who wrote Dreamland, that said maybe the best place for treatment is while people are incarcerated. And I like almost broke my heart that we could think that like literally the best place for people to get treatment, that they would have to be incarcerated before we could get them treatment. That is such a broken system. And he was highlighting some great work that's happening in Kentucky, but I think that we really need to rethink our entire model. And so I would say that we need more than 10 minutes and that we should focus on those three things. Addiction is a chronic condition, treatment works, and naloxone will save lives.
Hi folks, I have a question about so we've talked a lot about education, culture, and stigma. And I think those are the sticky issues that are really at the heart of a lot of this, that there's a lot of misunderstanding, there's a lot of lack of information, and then the stigma kills a lot of people, stops a lot of people from attending treatment, from people adopting medication-assisted treatment. My bent, I'm an addiction treatment provider, and my bent has a lot to do with the quality of our field. And what I'm wondering is what sort of initiatives can we take in order to raise education and awareness, even within our own field, where we have people, there's so many treatment centers where we're still calling people addicts, we're still calling people alcoholics, we're talking about dirty drops. There's a section of a historical aspect to our field that's very much rooted away from medicine, that's very much rooted away from science, and I'm wondering, are there any options through either national standards, DASA, ways to elevate the quality that someone gets even when they attend treatment? We talked a lot about implementation, and I'm wondering how can we raise the quality of our treatment centers?
Okay, so I am a master's student right now. I'm about to get my master's in social work in December. I cannot wait. I'm so over this. I'm just kidding. And one of the things that I even see in my own program is Case Western. Case Western's a phenomenal school. Is that there isn't a lot of person-first language conversations. There's just an assumption that it exists. And then there's a lot of, you know, kind of the old school utilization of prior, you know, treatment models that may work very well for alcohol use disorder or other types of use disorders, but not necessarily for opioid use disorder. So I think I see a lot of that, and I see a lot of my colleagues also very confused about what that means, and still having this kind of this jostle with like, where do I fall in this? When it really shouldn't be a question of where do I fall, it should be like, this is what we know. This is what's evidence-based, and I think we're still having a struggle with that, just like determining what works well, and I think that's pushed or pulled by whoever is kind of starting the conversation or leading the conversation. So I think that that we do have a long way to go with that, and I think, you know, my supervisor is in her 60s. She's been doing this for 35 years. And a lot of these concepts that we're discussing today, MAT, treating people with medication, it's new to her. So when we're doing continuing education, we need to be making sure that the continuing education requirements in the state of Illinois for social workers who are focusing on addictions or CADCs fall in the line of understanding how addiction works in the brain, all the things that kind of Elizabeth was alluding to. I think we need to start there because that's really how we're going to make an impact on the people now, and then making sure that the schools, Loyola, et cetera, are all doing their jobs in terms of the most updated types of practices that we need to be teaching.
Yeah, I mean, I think that part of it also starts with with the treatment providers that are in the room, and so I think that, you know, this is another situation where we can focus on the schools, but our return on that investment is going to take a long time. Also, you know, I've met a lot of CADCs who very recently graduated who say they didn't learn anything about medication-assisted treatment, who said that their trainer in their courses was still using the language that you just mentioned. Change is hard, right? Like, that's what addiction is, that's what we're talking about. Change is hard across the board, whether you're talking about your profession, and so I think that it has to partly come within. I think we need to start at education level. I think that definitely change can be sort of top down, so for administrators, really making sure that we're training our staff, but also it has to be from within the organizations. I also think that to the extent possible, we really need to start to merge our siloed systems and really be very serious about integrating physical health, mental health, substance use disorder treatment. We have to start merging those things, and we have to start really understanding what the evidence base is, and we have to start continue to really research and push that evidence base to make sure that we're understanding, you know, as people often ask me, well, why don't we have guidelines on what type of medication will work best for someone? We haven't really studied it very well. You know, and so I think that there are a lot of areas for continued research, and I think that change has to come from all directions, from continuing education, from people who are in school now, and from within organizations, because change is hard.
Hi. First off, I'm a recovering alcoholic and addict, and given permission to share that I'm also the mother of a recovering heroin addict. I have a comment and a question. The comment is, I don't think we can really tackle stigma until panels like this start including people who experience addiction themselves. So that, and the second thing, in my years of working on my own sobriety and also what I've observed with my daughter, I haven't heard anybody speak about the importance of self-help, 12-step programs, smart recovery, and the other tools that the people I know use in order to sustain recovery. Can somebody speak about that a little?
Sure. So at our facility, we offer all levels of that, and I just want to say to you, I am in recovery from certain things. I just haven't said it, and I don't know that it's. I appreciate your comment because I agree with you, but I don't know that the questions have been geared toward that yet. But thank you for asking that and saying that. I also think that that we have this. We have so many different types of recovery programs out there now. We have, like you said, 12-step. We have smart recovery, which we offer because we were told that there wasn't enough of it. And there were so many people coming through treatment environments that were saying, I don't connect with 12-step. I don't know how to find my spiritual place. And that's hard for people to say, and I think we have to meet them where they're at, right? There's also Celebrate Recovery, there's Refuge Recovery. I don't know that treatment environments are actually offering all. I don't think that they're actually including that in their models. And listen, if it's a faith-based treatment environment and 12 steps, the module that they're using, that's what they're using, and we shouldn't chastise them for that. But we should be offering more in terms of educating people on it, integrating it into treatment modalities, and really having conversations about it, because, you know, you're right, the face is, we're not the face of the epidemic, you know. So I do agree with you on that. I do think that there's a lot of confusion, and still, I call it stigma on top of stigma. There's stigma within the recovery community about what is the right way to recover, and I think that that's individualized for each person. That's what we know, that's what we've learned, and I think that this is a conversation we're gonna have to have more and more openly if we're gonna get anywhere with it and not be so afraid to talk about it, because I can't tell you, Dr. Weiner, how you're gonna recover today, and you can't tell me that, right? So I think just having the conversations are important and telling people about them. So you've just helped us do that. Thank you.
I think the only thing I would add is that I think there's, you know, obviously with the CARA funding, there's going to be an increase in funding for substance abuse treatment. I worry, this is outside of my role as a CDC professional, but just as an American citizen, around making sure there's fidelity to implementation and a benchmark to certifying those programs that are stood up in ways, because I worry about fraud, waste, and abuse. You know, catching, you know, because some of these programs are so very, very expensive. I'm sure you've all read the same articles I have about families being bankrupted from paying for treatment. Boy, I really want to make sure that treatment is evidence-based and gets people on their path to recovery in ways that is, as was mentioned, is individualized and appropriate for them, but that they get the outcome that they want.